Okay, well, it's 6 o'clock, so let's get going. Um, Hello, everyone, and welcome to our bowel cancer research webinar. It's great to have so many people wanting to join in. If I could just request if all of the attendees could make sure their camera and their microphones stay off during the webinar, um, then that would be great. Thank you. Oh, I can hear someone's microphone is on right now. Yeah, if we could all keep those off, please. Um, but yes, welcome to our bowel cancer research webinar. I'm Dr. Ruby Osborne, the Senior Research Interpretation Officer at Bowel Cancer UK, and I'm delighted to be joined by two bowel cancer experts. We have Dr. Kuram Khan of UCLH, and we have Mr. Chetan Ban of Whittington Health. And this evening, we're going to be discussing what's exciting in the world of bowel cancer research, what's coming up, and how this might affect patients today and in the future. And we at Bowel Cancer UK are excited to be part of this because one of the things we're keen to do at the charity is show how the money that's been raised by our supporters and our partners can best help bowel cancer patients now and in the future. So we look carefully at how we can use those donations to. Oh, someone says my voice is echoing. Is that a problem for everyone? No, no. Other people are saying that's all right. Sorry. So we look at how we can use the donations that people so generously give us in the most impactful way, and we think that funding the right research is something that can make a real difference to patients. And that's one of the reasons that we're about to launch our new research strategy to show where the funding that we put into research can make the most impact. And so our strategy, which is guided by our organisational focus on early diagnosis, is going to be launching in the next week or two. So keep an eye on the research pages of our website to find out more. We're also really happy to be working with our partners in this webinar, the National Institute of Health and Care Research, the NIHR. They support a wide variety of bowel cancer studies across the UK, working to improve outcomes for patients and transforming lives through research. And finally, we'd like to thank the Radio 1 DJ and presenter, Adele Roberts, who herself had bowel cancer and is living with a stoma, and without whom this webinar wouldn't be happening. Adele is a patient of both of our guests today. Dr. Khan treated her and Mr. Ban was her surgeon. And she's the person who suggested to the NIHR that they come to us at Bowel Cancer UK to help put this webinar together. So we're delighted to have her support, and she also shared the link to this on her social media channels. So finally, before we start, if anyone does want to know more about bowel cancer, including the symptoms and how to get support, then you can visit Bowel Cancer UK's website. That's www.bowelcanceruk.org.uk. And if you want to get involved in research, if you're interested in maybe taking part in something, you can visit the NIHR's Be Part of Research website. That's www.bepartofresearch.nihr.ac.uk. So let's get started. So to start off with, if we could just discuss, and I think, Karam, I think you're kicking this off. So what do we know about the causes of bowel cancer and the risk factors of bowel cancer?
Okay, thank you very much, Ruby, CRUK, and NIHR for the very kind invite. So first thing to state is the incidence of bowel cancer. So it's actually the third commonest cancer in the world. And the incidence, as we'll probably discuss later on, is on the rise, particularly in the younger patient population. To be honest, the exact causes of that are not entirely clear, but there are some broader causes of increased incidence of cancer in general, such as environmental factors, our oral intake, the type of diet that we have. But what is clear with bowel cancer incidence is that the type of diet has a strong influence on the risk that is generally involved. So low fiber diet, for example, is well established to be one of the key risk factors associated with development of bowel cancer. important thing to highlight here is that the hereditary factors, which can contribute to less than 5% of the overall incidence of bowel cancer, have a very small part to play. So contrary to the belief that, there might be a strong family influence, most of the bowel cancer patients present with sporadic causes. Sporadic meaning they would develop those genetic alterations throughout the course of their life rather than being influenced by their family members. So I think the key factors, the small risk is that of smoking, but the key factor is that of the oral intake, the diet, whether it is high fiber or low fiber diet. So there's a clear cut, association with that. And then there are some diseases such as, Crohn's disease, which has a link to bowel cancer as well. So although again, the link is quite not it increases the risk by some extent, but generally, again, the sporadic causes of the bowel cancer actually take the dominance in terms of how many patients present with it.
You mentioned fiber. Is there anything else in the diet that we're aware of that can have an impact?
So to be honest, again, not quite. As long as there is a high fiber diet, which is actually the manifestation of that is constipation. Okay, so a lot of people have constipation, which leads to long-term inflammatory episodes, and then that leads to a chronic, vicious cycle. But as long as actually it's an oral balanced diet, which again we are all aware of, not leading to obesity. Again, increased sugar intake has no direct correlation, but increased BMI has. So there are multiple factors which are indirectly linked, but in terms of direct linkage, I can't think of anything specific.
And you touched on it already that the cases in younger people, we're seeing a big increase, and we're not really sure what's going on with that, why that might be. But if people are perhaps younger than the screening age and they suspect that there's something not quite right, what should they be doing about that?
I think that's a critically important point because the first thing again is to state that, when Chet and I probably started our training, the incidence of bowel cancer in patients below the age of 50 was probably 5 to 10%. So in our typical clinic, the number of patients, if we were doing a 30-40 patient clinic, the number of patients that were below the age of 50 were quite small, certainly less than 2 or 3. Now, actually, we're seeing a sudden increase in that, real significant increase in that. And as we are aware that the suggested figures are 35% patients now are below the age of 50, and the predicted figures would touch probably 45 to 50% in next few years. As I mentioned, the causes of that are not clear. However, it is clear that the patients, there are probably going to be two peaks of this cancer. So in the younger patient population, and as we are already aware, people in their late 60s or early 70s. So 73 used to be the average age of incidence. I think it's an important collaboration between the patients and the healthcare professionals. So patients need to be aware of any alarming symptoms, because previously things like bleeding from the back passage, PR bleeding, which we refer to as, often in the younger patient population is attributed to things like hemorrhoids or non-cancer causes. And people also could be, a bit complacent about it when they're young. It's hard to believe that they could be diagnosed with cancer. So I think from patients' perspective, the important thing is to not ignore those symptoms and visit their GPs or healthcare professionals as soon as possible, because any of those symptoms, for example, change in bowel habit, again, people can go back to CRUK website to see what symptoms cause alarm bells. But in short, change in the bowel habits or bleeding from the back passage are the most concerning features, and they should seek a medical advice straight away. From the healthcare professionals' point of view, particularly the general physicians, I think it's now time that we take those symptoms seriously, because we still in our clinic see patients who've been on multiple occasions to their healthcare professionals, and the symptoms have been attributed to benign causes. And then that delays the diagnosis and frequently leads to late presentation with cancer. I'm sure Mr. Ban will be able to address this more, because he sees those patients more often in the clinic. When they come to us, they have generally already a diagnosis of cancer.
Yeah, chat if you want to.
Yeah. Yeah, so I think, just to reinforce what Dr. Khan has said, I think particularly rectal cancer is on the rise, and particularly in the young age group. So there is some data to suggest that by 2040, 50% of patients who have rectal cancer will be under 40. Rectal cancer itself is more difficult to treat and often will require radiotherapy. It's very important, as particularly for young women who are of childbearing age, because radiotherapy will then have a long-term effect on their fertility, but as well as the surgery itself and other drugs that are needed for treatment of that particular type of disease. So we have bowel cancer is colorectal cancer, so large intestinal cancer, either from the colon and the rectum. And the prognosis for patients who have rectal cancer is usually worse than it is for those who have colon cancer. That's very dependent, obviously, on what stage you present, but generally rectal cancer is more difficult to treat. Patients are left with longer term problems such as permanent stomas, infertility, and other pelvic organ problems, bladder problems, etc., as opposed to colon cancer. And I think to reinforce things, so understanding that actually, although we can't control, there is something environmental that is causing this to the increase in bowel cancer in our country and other high income nations. We obviously we haven't got as much control over that, but what we can do is try and detect the disease early. And we do understand the development of bowel cancer we have a very clear understanding of how it develops. It's something called the adenoma carcinoma sequence. So bowel cancer will develop from little growths called polyps. And it takes many, many, many years for those polyps to become cancerous. And if we can pick up these polyps at colonoscopy, they can be removed. Patients they can then be sort of aware that they're slightly more at risk, and depending on how many polyps they can have regular colonoscopies to have these removed and avoid the risk of getting bowel cancer long term. And I think that's the important thing, particularly for young patients. When they have symptoms, bowel symptoms can be very non-specific, and often, particularly for young patients, they get labeled very early on that they may have irritable bowel disease. This is IBS. We saw this a lot during COVID, where access to healthcare was reduced, and we saw patients presenting young, well, at all ages, but particularly young patients presenting later with emergency cancer, bowel obstruction, etc., related to cancer. So it isn't, I think, in the healthcare professionals' minds as well, there has been this dogma that, if you're under 40, you don't really need to be investigated for bowel cancer. You probably, as Dr. Khan said, you probably have hemorrhoids. You may have not a full colonoscopy, something called a flexible sigmoidoscopy, not have a complete examination, be reassured, and then discharged and given general dietary advice, or have hemorrhoids treated. I think it's very important knowing that it can take up to 10 years for these little polyps to grow. You can understand that someone who develops a bowel cancer at 40 we may have been able to detect it in their early 30s that they had these polyps and they could be removed. And I think the other really important thing that I've had a few patients who misunderstood is this difference between asymptomatic patients and symptomatic. Asymptomatic people and patients, symptomatic patients. So I have had, you probably are aware of National Bowel Cancer Screening. That is a population-based tool, health screening tool. So all it is doing is it's a poo test that looks at how much poo, a volume of poo volume of blood, that you have in your poo. And a level of 10 is what we call positive. Now, if you're a person who has bowel symptoms and you go to your GP, they will do that test. And if it is positive, they will say, or if they're worried in any other way, they will send you on a cancer pathway to your local hospital. Now, if you get up one day and find in the mail the pack for the bowel cancer screening, and you do the test and you send it away, Nothing will happen unless you have a value of 120. Okay, so I've had patients come to me and say, I had some symptoms about 3 or 4 months ago, but I had the screening kit come and it was negative. So I was reassured. The reality was when I contacted the screening center to find out the value, that their number actually was high, it was positive, but the screening level value triggers much higher than the actual what we call a positive test. And the patient had, that particular patient had a rectal cancer, and it was diagnosed, I think, more than 6 months after the original bowel cancer screening kit had been sent to their house. So it's important, if you have symptoms, that bowel cancer screening, a negative result from that bowel cancer screening kit is not any use to you. You need to go and see your doctor. The reality was, if we had the resources, everybody would have a colonoscopy at 55 or even younger to rule out or obviously rule out cancers, but also to look at polyps, and have those polyps removed at that stage and avoid developing a cancer later on in life.
So a great point as part of that is that obviously diagnosing these things as early as possible gives people the best outcomes. So as well as the fit kits and colonoscopies, are there any other potential diagnostic tests coming through? There's a lot of talk about blood tests and particularly multi-cancer blood tests. Do you think there's some potential in those?
Yeah, I'm happy to take this question. So this is a concept of circulating tumor DNA, what we refer to as liquid biopsy. So it's a very exciting avenue. Actually, a decade ago, my research was on circulating tumor DNA. So the concept is that the tumor cells shed these cells in the circulation, and you can pick them up through very sensitive test, just a plasma test. So first of all, the exciting part is that you only take a blood test, and if you have a good technology and a good sensitive test available, you can detect that circulating tumor DNA, which will be suggestive of a possible cancer diagnosis. Now, obviously, the tests are developing all the time. There are multiple kits, there are multiple different panels. And at the moment, although we have access to a lot of these tests, there are a few things which need to be calculated in time and determine what would be the best test for diagnosis of a specific cancer. So what we have at the moment is, if we have firstly knowledge of the cancer, we can quite smartly look at shed of these cells, plus we can look at certain specific mutations or abnormalities, which will guide us in terms of treatment for patients who have established diagnosis of cancer. We also have these panels which are coming into early phase, for example, in general population, where we can do the test, and that will guide us if there is any evidence of potential cancer or not. That would not, at the moment, it would not probably give us specific information about bowel cancer, although there are some mutations, you can interpret them that they are more common in certain cancers like bowel cancer, and that can guide you towards that, but they're not definitive tests. But what we are looking forward to is that more development of these tests, such that we will probably be in next 5 to 10 years time in a situation where people could have those tests that guide us actually that this is, for example, there is some concern about the cancer, then that can lead to set of investigations which can then guide us to more specific investigations such as colonoscopy. I think it's important to highlight that we're not at the stage where these tests would replace the gold standard tests, like Mr. Ban has said. So, the colonoscopy for bowel cancer diagnosis would remain the gold standard for now, and probably in near foreseeable future, I cannot see that being completely displaced, because also important to highlight to general population that, the importance of these tests is there, but for histological diagnosis, we still actually rely on the biopsies, which are very important tests. We need that information to be there in order to benefit from these additional tools. So I think in short, there is very exciting avenue of circulating tumor DNA liquid biopsies, which will be the standard of care for a lot of patients in future, but those gold standard tests will probably remain there and will help in terms of management of these patients.
I think just to add, colonoscopy is important in many ways because you can take a tissue, you can take a specimen, you can remove a polyp, you can take a biopsy when it's normal, actually. So some patients who have diarrhea, you take and the colon looks normal. We do something called random biopsies, and they can have, in only a small percentage, but they can have something called microscopic colitis. So you glean a lot of information from a colonoscopy. An alternative that has become popular in the last 15 to 20 years is something called CT ventral colonoscopy. Um, that is used that is used as an alternative, and it's a CAT scan, CT scan with a special preparation. It is still invasive because the patient will have a little tube put into the bottom and air pumped into the colon to distend it completely, and then they have some very fancy software that reconstructs it and looks like it allows the radiologists, they're the doctors who look at CT scans, to have a kind of fly-through view of the colon. But the problem is that we know that 15 to 20% of patients who are symptomatic and being investigated for bowel symptoms will have polyps. And so those patients who have a CT colonoscopy will then have to have a colonoscopy and have the polyps removed. So I think colonoscopy is still very much the gold standard. It has become better. It obviously has risks, but through a concerted effort in this country, we have improved quality through very, very careful standardization of outcomes and audit of colonoscopists, ensuring that people who do it are doing lots a year, 200 plus a year, and that they have certain quality metrics that they're hitting, and if they're not, they can't do it. So we're seeing complication rates. And complications are not just a problem 20, 30 years ago. It was not just that patients got complications where the bowel got perforated. It was the fact that a lot of people were doing colonoscopy and not realizing they hadn't got round to the end and missing cancers. Because all you know when you're doing a colonoscopy is when you're at the anus and when you're at the other end at the junction with the small intestine. And that wasn't always realized. Patients were having incomplete procedures, cancers were being missed. So I think it is definitely still the gold standard for all those reasons at the moment.
So
Afraid to have one is what I'm really trying to say. Is I know I have patients come to me and they really don't want a colonoscopy. Of course, it's invasive. It's done under a sedative, but it is. I mean, what if it's normal? That's great. If we find polyps, that's great because we've prevented you possibly developing a cancer in a few years. So.
And moving now from diagnosis into treatment, what new developments are happening in bowel cancer treatment? Are there new drugs coming through the clinical trial pipeline, or maybe new combinations of drugs?
Sure. So I think we can divide that question. That's a great question, Roby, into two parts. So I can take the part of the drug development, and then I think Mr. Ban can probably talk about the surgical techniques and, for example, robotic surgery, etc. So in terms of the drug development, the first thing to say is that obviously the most exciting avenue has been development of immunotherapy, which is now part and parcel of the treatment in a specific proportion of patient population who have a certain gene abnormality. So it's important to highlight because a lot of patients come with the belief that immunotherapy is fantastic, which it is in those patients where it is likely to work. So there is a protein called MMR protein, which has 4 different components. And essentially any abnormality in that protein actually almost guarantees your response to immunotherapy. Guarantees mean more than 80% chances of almost complete response to immunotherapy with very low risk of relapse. Although it is never alleviated completely, but the risk of relapse is very small. That is just 4% of the patients who present with metastatic disease, so disease that has already spread to other parts of the body. In early stage cancers, it could be 15% of the patients. And again, in those as well, the treatment pathways are evolving, but the current standard of care still is to offer them surgery. But immunotherapy is one of the most exciting avenues, as I said, for that patient population. Now, there are some other indications where immunotherapy might work. For example, there's a rare mutation which is quoted to be 1 in 100. It's called POLE mutation. There's another mutation called POLD mutation. So these are very rare mutations, and they're not routinely checked. But through these wider liquid biopsy panels, we can look at them. And if the patients have that, they're also likely to have an excellent response to immunotherapy. In terms of other drug development, I must confess that in last decade or so, actually, the number of drugs available for bowel cancers have remained a little bit stagnant. Although more recently, a few new combinations have been approved, which is very positive. So in patients who have metastatic disease, and they have exhausted 2 standard lines of treatment, now we have at least 3 treatment options. So what it has meant is that a lot of data show that people who had several lines of chemotherapy or other systemic treatments in bowel cancer or any other cancer, they're likely to live or survive longer. Now that is complex. Obviously, one could argue that they are likely to have good disease biology. They're more fitter, healthier patients. That's why they're able to have several lines of treatment. Nevertheless, having multiple lines of treatment gives you better outcomes. So we have, for example, recently, it was a very positive decision from NICE that Lonsurf, which was one of the drugs which was already approved, is now available in combination with bevacizumab, more popularly known as Avastin. And that was only last month it got approval. We already had approval for regorafenib, which is another tablet form which attacks the blood supply of the tumor. There's a new drug which has just received MHRA license. It's called fruquintinib. It also attacks the blood supply of the tumor, and it's much better tolerated compared to some other agents. So we have now at least 5 lines of treatment which are available for bowel cancer patients. And then in those patients who benefit from immunotherapy or other targeted therapies like cetuximab or panitumumab, which again, there are antibodies but work for specific group of patients. I think it would be not within the scope of this discussion to go through more details of that, but the main point is that we have these developments. Now, one of the most exciting avenues, as far as I'm concerned, is the development of vaccines, which actually, again, there are a number of trials. There are at least 2 different companies which have developed these vaccines, messenger RNA, mRNA vaccines. And the concept is not much different to the concept of immunotherapy. So if I go back on that, because it's an important subject, for last 50 years or so, we were aware that one of the hallmarks of cancer is that when cancer cells are attacking the body, the immune system fails to recognize them. So over the last 40 years, the research had unfortunately failed in development of any immunotherapy drugs which could kind of reignite your immune system to fight against the cancer cells. And then came these drugs into being in last 10 years or so, like ipilimumab, nivolumab, pembrolizumab. So there are a number of these drugs which attack some checkpoints in that pathway and reactivate body's T cells to fight against the cancer cells. So the whole concept is fascinating that, rather than the typical concept of chemotherapy, which actually attacks the DNA of the cells, and then it cannot select between the cancer cells and normal cells, hence the reason why people get so many side effects from these treatments. The immunotherapy kind of reinvigorates your whole immune system, which fights against the cancer cells. And that's why when it works, people have long-term remission or response to the treatment. The same concept is that of vaccines. So you kind of make your cells reactivated again, and your T cells and your immunity, the concept is that it becomes active against the fight, and that takes control of the cancer and attack the cancer cells. So that's in the simple way of describing it. So obviously always has been an exciting concept, but this is the first time that we are seeing it closer to reality. It's now actually happening in clinical trials. We also are launching one of the trials at University College London. In fact, the government of UK has actually started this very good launch pad where all the vaccine trials would become available for general population. Although just a very quick point on that, I think there's some miscommunication there, though. Some people were under the impression that they can access the vaccines. The concept of that website is to have, details of all the available trials rather than the fact that they are available to everyone.
Okay, and I think still, despite what Dr. Khan has just said, colon and rectal cancer are very surgical diseases. So the mainstay treatment, what Dr. Khan has talked about, is those patients who have later stage disease and metastatic disease. When we diagnose a patient with bowel cancer, we initially stage them. And that staging is with a CT scan, with the biopsy result, looking at some of the genetics, and to see if it's spread anywhere, and to see how big the tumor is itself. And we divide it into 4 stages. And stage 1 is the very earliest disease. It's when the tumor itself is grown a little bit into the bowel wall. The tumors start in the lining of the bowel. Imagine a bicycle tire. So the lining is the rubber tubing on the inside, and the muscle is the tread of the bicycle tire. So the tumor grows in the lining, and if it's just really confined to the lining and maybe just starting to get stuck onto the bicycle tread, that's what we call a stage 1 cancer. Stage 2 is when it started to invade into that bicycle tire, into the tread, but it hasn't gone through it and it hasn't gone into the lymph glands. And then stage 3 is when it started to involve local lymph glands, and stage 4 is when it is now spread to somewhere else outside that local area. Stage 1 and 2 cancers, broadly speaking, are surgical only. So not all patients need chemotherapy or to see an oncologist, sorry, Karam. And we can cure just with the surgery, and then the patients you would be followed up for a period of time, usually 5 years afterwards, to make sure that the cancer doesn't come back. And for stage 1 and 2 disease, the survival at 5 years is usually between 80 to 95%. What we've seen in our where we've seen advances in surgery 20 years ago, you'd have to have a big open cut and part of your bowel removed. The other thing, just to reinforce, often patients don't understand the concept of how much we have to remove. We remove sections of the bowel. We do not just remove that small cancer, which might be 3 or 4 centimeters. We have to remove a segment of the bowel because we have to remove all the lymph glands that are draining that. That's part of how we stage the cancer, to make sure that it hasn't spread into the lymph glands. We don't have any really accurate tests or imaging or blood tests or any other type of scans to accurately tell us that. So we, at the time of surgery, have to remove a section of the bowel with its blood supply, and that takes all the lymph glands with it. What we've seen over the last 20 years is the development of keyhole surgery, which is now the standard of care. And really, if you have family and friends who are having bowel cancer surgery, they really should be having it with a keyhole technique. And that is very much being endorsed by our Colorectal Association. There were trials done 10, 15 years ago that showed a huge benefit, not just cosmetic, but for recovery, and no disadvantage in oncology. But what I mean by oncology is a disadvantage in the cancer quality of the cancer surgery itself. Now we're seeing what started for prostate cancer, we're seeing the development of robotic surgery. Now, you might have heard this in the news, surgery with robots. In fact, I think one of not West Streeting, but one of the junior health ministers, quite ignorantly, I thought, said, oh, in Lancashire, robots are doing something and treating patients, so the surgeon doesn't need to do anything. That's absolute nonsense. Da Vinci, which is the robotic system that's been around now for about 20 years and probably the most advanced, is a form of keyhole surgery. So you still have to have the little ports where instruments are placed in, but instead of the surgeon being at the bedside and placing the instruments in, and doing the operation, looking at TV screen. The arms of the robot go in, and the surgeons at a console in the same theater, not in another planet or on another country or anywhere, in the same theater, but has a three-dimensional view, magnified three-dimensional view, and also, unlike keyhole surgery, where we have it's like operating with chopsticks versus operating using your full wristed movement. So we're able to do much more accurate surgery, and particularly for things like rectal cancer, where the surgery is much more demanding, and where there are lots of important nerves supplying other organs in the pelvis, we can see those more clearly, and we can perform much more accurate surgery. And it seems from that type of surgery also that even though it's keyhole and it has the same number of cuts as the keyhole surgery, patients seem to have less pain afterwards and even less quicker exit from hospital, so a shorter length of stay. So that's our latest development, and as well as the technology of the surgery, we are in combination with our oncology colleagues now being much clever about how we manage surgery, being much more multimodal. So looking at ways we can treat patients in non-traditional methods or non-traditional orders. So classically, a patient would be diagnosed with a bowel cancer. If it was operable, they'd have surgery, and then if they needed, have chemotherapy. Now, sometimes when we stage a patient or get their initial investigations, we may think, actually, this patient, it looks like they've got big cancer and they're likely to need chemotherapy. Let's give them a bit of that first and make it a little bit smaller so that we can make sure we can clear it better and they get a better long-term result. Or with rectal cancer, let's give radiotherapy and we can shrink it down to make sure that we can remove it cleanly. And again, make sure the patient has a better long-term result. Use genetics, as Dr. Khan has talked about, whether some patients may benefit from immunotherapy instead at the beginning. And we're seeing in some cases, particularly in rectal cancer, if we use combination of very high dose radiotherapy and chemotherapy beforehand, in a small number of patients, the tumor can disappear completely, although we don't know really what the long-term prognosis is in those patients who are not operated on. We know a certain percentage of them will get recurrence and then need surgery. So we're still early on in that journey, but there's, I think the most important things are our surgical technique is becoming more precise, standardized. The technology we have is allowing that. And also we're working much better with our other non-surgical colleagues, our oncologists, in a multidisciplinary way to make sure the patients have the best outcome. And we are, as we're having a younger, not that it's not the same for an older population, but we are having to think a lot more about function long-term and consequences of the treatment, consequences of cancer treatment on patients who may then live 40, 50 years, or as I talked about with rectal cancer, young women of childbearing age, and how we treat them and how we make sure that we have, we come up with a plan together with the patient, not taking unnecessary risk, but to be more pragmatic sometimes. Particularly my rectal cancer patients, often I will, because they're young ladies, they're usually very healthy otherwise. We can try and avoid radiotherapy to protect their fertility, avoid stomas as much as possible, because we understand that they have better healing, better tissue, often have less in the way of what we call comorbidities, other medical problems such as diabetes, problems with the immune system, and things that can cause problems with healing and then obviously result in long-term complications.
And so we've been talking about surgery on the bowel, because I think it used to be the case that once the cancer had spread to other sites, surgery wasn't really considered an option. But I understand that there's some advance in surgery for bowel cancer that spread to the liver these days.
Yeah, so there are and I'll let Kurum talk about certain oncological techniques, but we are now, as I tell my patients, we are now seeing bowel cancer is in some cases becoming a chronic disease. There are patients who have lived sometimes 15 to 20 years with cancer, low volume disease in lungs, etc. When we see a patient who presents with stage 4 disease, for example, we will look to see at the beginning whether this is operable, what we call operable stage 4 disease. For example, if you have a tumor with some liver metastasis, spread to the liver, some liver metastasis, we'll usually get a liver surgeon involved very early on to say, can this be removed safely? And if so, maybe they want to do that at the beginning, or we'll give chemotherapy, or we'll look and see how we can plan that patient's care so we can remove all the disease that's there. Dr. Khan and I have had a patient who's young, in their early 40s, present with a rectal cancer, 2 liver metastasis, and a 1 lung metastasis. We therefore, but he was about to block his bowel, so instead of just rushing and doing a big operation, emergency operation, we gave him a temporary stoma to deal with that problem. It allowed him to have chemotherapy quite quickly because he didn't have a big operation to recover from. He had chemotherapy first, which kind of shrunk everything down, and then a liver surgeon and myself operated on him. I removed his rectal cancer. The liver surgeon removed half his liver. Dr. Khan will now give him the rest of his chemotherapy, and then we'll ask a lung surgeon to remove the remaining disease, and then after that he'll go into follow-up. So there's that in those types of patients. There's another group of patients who develop recurrences, so they've had their surgery and it comes back in their tummy in various places. It can just be floating in the tummy outside the organs. We call that peritoneal disease. That is, if you imagine your abdomen, your bowels and everything are basically free floating in a bag. Imagine like a Sainsbury's bag, which is called the peritoneum. So if you have free cancer within that, we call it peritoneal disease. Those patients often would have a very, very slow and difficult progression and ultimate death from cancer with very few options. We now perform something called intraperitoneal chemotherapy. So in patients who have this type of disease and are eligible, we will do an operation, remove everything we can see, and then we put chemotherapy into the abdomen, a specialized type of it's heated chemotherapy because it works better at 42 degrees centigrade, and then finish the operation, and that's their mainstay treatment for that type of disease. And we have patients where it recurs, particularly rectal cancer patients, where they need, and if the patient agrees, we can do quite complex surgery. Often it requires removal of, depending where the tumor is, it can be removal of part of the sacrum, but it can be quite major surgery, and still we can cure patients. So we don't anymore say, oh, it's come back, or it's spread, or it's a diagnosis. There you go, off you go to see the oncologist and see what they can do for you. We're very much trying to see what solution as a multidisciplinary team there is to try and cure the patient, if we can.
Yeah, that's great actually. So I think Mr. Ban has already highlighted how so I think that all highlights the importance of a multidisciplinary team. So, it was always in place actually, but the value and role of multidisciplinary team has evolved over the last few years, because now actually there are many situations which were just considered to be surgical situations. Likewise, there were many situations which were just considered to be oncological situations. But now there's a lot of overlap. So there could be patients who presented with very early stage disease, but yet they could have functional implications in terms of directly proceeding with the operation. We've already touched upon the rectal cancer patients. Likewise, people can have metastatic disease, and the concept could be just to write them off, but that's not true anymore for a lot of patients. However, that's where the careful decision making is important, because if, for example, there's a patient who has widespread liver metastatic disease, it could be counterproductive going for an operation at the wrong time point. On the other hand, if you achieve enough shrinkage such that the surgery becomes a viable option, then clearly the importance of that discussion is that we keep going back to our multidisciplinary meetings and keep asking the questions so that we do take the right decisions. Now, apart from all these advancements that we have discussed, one of the exciting avenues which hopefully will become standard of care in future would be liver transplant in liver-only metastatic disease patients. So there was a trial, pan-European trial, which was recently presented in the American meeting called ASCO and the European meeting called ESMO. And that showed that patients who had liver-only metastatic disease, so the cancer right from the beginning had only been confined to the bowel and the liver and could not be resected because there was multiple areas of liver which were involved. Those patients, if they had a sustained benefit from chemotherapy for a period of time, they were offered liver transplants. And then their 5-year survival was 60 to 70% compared to 8 to 9% without the transplant option. Although a lot of them relapsed again, so it's not still at a stage where it could be considered as curative for all. But I think the important thing was that we have discovered a new treatment option for patients with liver metastases. As Mr. Ban has said, we have a number of patients which we are looking after in our joint care who had either liver metastatic disease or some small lesions in the lung, and we've resected liver and lung separately, and then they were back on chemotherapy. I think the important thing though is that it's a long journey for some patients, and it could be a chronic disease, as Mr. Ban said. But we have more treatment options than we used to have, and we are more aggressive in treating these cancers than we used to be. So these days, actually, based on fitness, I would rarely actually deny any patient treatment. Even if the patients are in their 80s, we've treated patients who are in their late 80s or even a 90-year-old. As long as they're fit for treatment, I think the important thing is to consider them for treatment and not to deny them based on any other factors.
I just want to reinforce that I did work for 2 years at the end of my training in Australia, and the mentality, when I think back, this is 15 years ago, when I think back of our mentality in this country then towards age, for example, colonoscopy screening would end at 75. And, in Australia, I remember one of the nurses, we were having a conversation about that, and she said, well, my mother's 92, and if you told me she couldn't have her operation for bowel cancer, then I'd go and find someone else who can. And I think I've had quite a few patients on the other end, quite a lot of nonagenarians that we've operated on, and they've done very well. We know that those people who get to their 80s and 90s with a good quality of life actually have a pretty good underlying physical health, and actually it can be a problem for us, and we have more comorbid patients in their 60s and 70s where it is difficult. But this is not, we moved away from a paternalistic attitude. This is a two-way conversation with a patient. Some patients who may be young and healthy may not want aggressive disease, mutilating surgery, etc. But older patients who may not be, we can discuss and we can advise and we can talk about risk. But I think it's important that we have those two-way conversations. And just from Kurum and I obviously work in UCH with what's called North Central London, our local hepatobiliary services at the Royal Free Hospital, and they are now starting and looking to recruit patients for liver transplantation. So if you have family or friends who maybe fit that criteria, it is starting to. There are a few centres across the country that are starting liver transplantation within the next 1 to 2 years.
And so I'd like to go back to something that was mentioned a little bit earlier. So there was the example of immunotherapy being good for people with a certain MMR mutation. Do you think that there are more genetic individualities, I guess, that we are going to find and are going to lead to more personalized treatment plans?
Yeah, no, that's a very important question. So obviously, I also touched upon these rare POLE and POLD mutations, which we are aware of. But the field of immunotherapy is expanding. So a little bit of extrapolation from some other cancers. So for example, upper GI cancers, although different disease, but there are some commonalities between these cancers because they still belong to the gastrointestinal tract. So upper GI cancer management has been transformed with the addition of immunotherapy. There is an additional marker called CPS score, which is PD-L1 expression score. It's one of the proteins which is expressed by the cancer cells. The higher the number of the protein, which is counted through two different methodologies, the better are the chances of response to immunotherapy in that particular disease. So at the moment, actually, in bowel cancer, we're not sure if that would have any direct influence on how well the immunotherapy works in a proportion of patients or not. But there are different things ongoing, actually. So there are combination of checkpoint inhibitors. A checkpoint is basically just in simple terminology, the T cells are inhibited by certain proteins in that pathway. And these immunotherapy drugs try to inhibit those proteins at different points. Okay, so PD-L1 is the famous point against which we have number of drugs which are working very well. Other point is called CTL4, which is also one of the well-established targets, and there are drugs which target that. But there are new ones as well. So for example, there's one called TGT, TIGIT inhibitor. There are other inhibitors which the concept is that you try to make the cells more prone to or immunosensitive such that the immunotherapies work in also patients who do not have that typical gene abnormality. So there are trials underway in patients who have already progressed on 2-3 different lines of treatment, and they're combining 2-3 different types of immunotherapy drugs to see if that generates that immune response and that enhances the chances of response to immunotherapy, even in patients who do not have those mutations or abnormalities. So indeed, it's again an important aspect of the research, because sometimes one can be frustrated that the results are slow. When you look at the overall development of the drugs. And just for the audience, I think it's important to highlight that the development of a drug goes through very stringent processes. So it's first tested in the lab. You need to find a drug which has effect on the cell lines or mouse models. And then, once you're aware that there is, a drug which has potential benefit, then you take it to the humans in the phase 1 trials, whereby you actually just are looking at the safety of the drug, although you know that there is some potential benefit, but you're not actually evaluating the benefit in those trials. And that's also important because often patients ask about the trials. So those are the early phase trials. Then if you've gone through that process and you've demonstrated that the drug is safe, you go take it through phase 2 trials where you could be a little more specific. Sometimes there are more generic trials, but you could be more specific if you find a signal that it has activity against certain cancer cells or certain type of genes or certain type of diseases like bowel cancer. And then it goes through the next phase, which is phase 3, where you evaluate it in a particular cancer type or a particular genes type. So the process is long, but the process is there, and that's why in the end we find these results. So what I would encourage the audience to think about is that it might sound frustrating, but it's an important process because there is no there's no way of actually bypassing the process, because we need to come up with those drugs in due course. So indeed, coming back to a question, there are more avenues actually in terms of development of immunotherapy, combination of immunotherapy with other immunotherapy drugs, plus with other chemotherapy drugs. So there are trials which are also evaluating if you combine chemotherapy with immunotherapy, would that work better? Recently, there was a trial that also showed that chemotherapy could be combined with the BRAF inhibitors. So a proportion of patients can have BRAF mutation, which is about 12 to 15%. That disease tends to be more aggressive. And how best to deal with that disease? Sometimes we give drugs which inhibit directly that BRAF genes, but now we are trying to combine chemotherapy with those inhibitors to to enhance the chances of that combination working. We have some patients actually, again, Mr. Ban and I have some patients who, despite the BRAF mutation, had operations and they've done really well actually, contrary to the general belief that they have very short time to live. So I think the field is evolving all the time and there are many exciting things coming through.
I'm conscious that we've only got 5 minutes left. So as a final question to both of you, which leads on quite nicely from what you were talking about, clinical trials. So all of the advances that we talked about this evening, obviously we need the researchers and the clinicians to run those trials, but they couldn't happen without the patients who take part. So from the patients that you work with, why do people get involved in research?
I feel, first of all, very privileged to be looking after the patients with cancer. To be honest, I mean, I've throughout my training, obviously, we were in different specialties. And one of the reasons why oncology was most exciting field for me was that obviously patients are suffering from an illness which nobody wishes to have. And it's a bit of a philanthropic aspect to that as well. So my research actually was looking at patients who offered biopsies, which was not of direct benefit to them. And we did, so we obtained 200 biopsies basically of all those patients who were fully aware that they had no benefit to them. And we did a survey afterwards, and more than 90% were fully aware that, that the process would not benefit them, but they said they wanted to contribute to research. And this is actually a real honor for us.
Yeah.
We are treating those patients, who are so determined that they are aware that they have a short prognosis. That was the situation. My research was in patients who had generally less than 6 months to live. And they wanted to help the cause of management of future patients. So I think that's the motivation our patients have. So we are so privileged, and that's what keeps me going as well. That, there are some depressing situations. You're sitting with very young patients where you can't offer a lot of hope to them on occasions. But at the same time, real hope is this research, which will hopefully in years to come by take care of most of the patients with bowel cancer or any other cancers.
Yes, obviously, research at that level is mainly performed by the oncologists. We're often involved as well, particularly in surgical trials. We have a current trial at UCLH, which is looking at immunotherapy prior to giving patients immunotherapy and then operating on those patients who have MMR deficiency. And these are randomized trials, so patients know very well that they may not get whatever they think the preferred drug is, but they're very happy to sign up. They're very happy to get involved. And I echo what Dr. Khan said. Often they know that these trials will not benefit them directly, but will benefit people with bowel cancer in the future, maybe their children, friends, relatives, etc., and they're very happy to get involved. So I think it's it just shows what a great country we are and population we have, and how we all do pull together when we need to. And I think on the last note, I think it's really important that if you're being treated by a team, if you get the diagnosis, that you're treated by people who are experienced in managing patients with bowel cancer, all aspects, both the oncology and the surgery, and do it regularly, because it's very important for long-term outcome to make sure you get the right treatment at the beginning. And I think I very much believe that. And it's not always the way across the country. There is still a lot of variation. And we do hear, you probably hear in the news quite a lot about our outcomes in general for cancers of all types when we're compared to other places in Western Europe. And I think it's important that we get these things right. We make sure that patients get consistent treatment across the country, and we diagnose better earlier and actually avoid patients developing bowel cancer in the first place.
Well, that brings us to the end of our time. It's possible that Zoom will kick us all out when 7 o'clock hits, so we will wrap up now. Thank you so much to our guests, Dr. Khan and Mr. Ban, for your wonderful insights. And if anyone listening does want to get involved in research, then you can go to the NIHR website that I mentioned at the start, or indeed talk to your clinical teams because they will know if there are any trials running locally that you might be eligible for. But yes, thank you very much.
Thank you very much, everybody.
Thank you, and thank you for all the lovely comments in the chat.
Thank you very much to everyone. Thank you.